Welcome back. Thank you for joining us. If you were so lucky to attend the last Paris Vascular Insight, we probably spent some time together during the carotid session. So thank you for coming. And if you did not have the chance to join us in Paris, make sure you book your dates for next year, because we will have really challenging and amazing topics to discuss together. Anyway, we are here to continue the story we began a few weeks ago. I would like to thank you, first of all, for your massive responses. It was great to see your comments, your feedback, quite impressive and quite consistent. You all had a lot of different opinions, but the main issues of the case were attended and discussed. And it's time to share with you the solution, at least what we did with this patient. Let's start with a quick reminder of where we were. 71-year-old male with hypertension, diabetes, dyslipidemia, previous cervical surgery plus irradiation, triple CABG with current triple coronary disease that needed treatment from the cardiology side, severe mitral stenosis, also needed treatment, chronic atrial fibrillation, and a carotid story of a minor stroke in 2018 or because of a right carotid occlusion, and 2 current documented TIAs, left hemispheric, because of a symptomatic left carotid artery stenosis. The 3 questions we had, or which we finished in the last conversation, were: should we plan a carotid intervention for this patient? Remember, we had the carotid history, the coronary history. Cardiac surgeons wanted to fix the coronaries, but they consulted us to know our opinion about treating the carotid or no. And if we were treating, asking if it was before, during, or after cardiac surgery. And indeed, that was my question for you guys. As I told you, many responses to this question, and their answer for the first question was quite consistent in the audience. The answer was yes. Should we treat this patient? I think there is no question about it. We have a symptomatic greater than 50% carotid stenosis with a coronary disease that needs treatment. So yes, we have to treat the patient. The second question was when? And your answers were consistent too. When is as soon as possible and before cardiac surgery. The indication of our guidelines is quite open. We can treat the patient before, during, or after cardiac surgery. So finally, it leaves the decision to you in your daily practice with your patient and with your multidisciplinary team. So when it is clear, should we plan is clear too. And probably the next question is, what kind of treatment should we offer the patient? Because again, in the guidelines, the treatment recommended is carotid endarterectomy. You remember, maybe the high-risk criteria or the classical high-risk criteria for endarterectomy are quite challenging or something we could discuss deeper. But in this patient, we had 3 high-risk criteria that are quite obvious. We have previous cervical surgery, so an irradiated neck, a hostile neck for surgery, current triple coronary disease, and a contralateral occlusion. The 3 items are clearly related to higher risk of stroke and morbidity after carotid endarterectomy. And that's the reason why all of the answers were thumbs up for carotid artery stenting. I think it's a really good patient for this. Remember, the decision about stenting should be based on the kind of lesion we have, on the kind of access we have, and then we have to decide the neuroprotection strategy. According to these options, your answers were slightly different. Some of you decided carotid artery stenting without specifying access or neuroprotection. Some of you went to transfemoral carotid artery stenting with distal protection, some of you with proximal protection, and this is what we did. We had these three options. We went for stenting as you guys, and we chose using direct transcarotid access plus flow reversal as neuroprotection system. You know, we have this device in the market. Well, we had this device in the market in Europe called root transcarotid neuroprotection system. The technique is TCAR, transcarotid artery revascularization, and briefly, it consists on an arterial sheath in the common carotid artery, a venous sheath in the common femoral vein, and a flow line that connect both. And while we are treating the patient, we are reversing the flow in the brain and protecting from brain embolization. Unfortunately, right now, this device is not available in Europe. So in our group, we did have to step back to the past, and maybe instead of using the latest technology, like the latest iPhone or smartphone, we used something more simple, but quite reliable anyway. The story of TCAR started in Spain more than 10 years ago, and the system itself is based on a homemade system that was quite simple, but really smart. We have an 8 French common carotid artery sheath, another 8 French in the internal jugular vein, and when you connect both and clamp the common carotid artery, you had the flow reversal. The technique was described in 2004, and we were able to prove a significant reduction in terms of brain embolization. So this is what we did to the patient. This is our first, I'm sorry. Let's see if the video goes. It's going. We have the surgical retractor, so you can see the transcarotid access, the sheath inside the common carotid artery, and the first angiogram showing the tight stenosis. We use a cigar stent, which is a mesh cover stent, one of the latest generation of carotid stent devices. We presented the 30-day data of the Iron Guard trial during the last PVI meeting, showing a below 1% incident of stroke after procedure. So we went for this stent, nice result, finally. And the patient luckily did well 4 weeks after carotid stenting. He went for cardiac surgery, recovered well, and he is right now uneventful. Indeed, we completed the 1-year follow-up, and he's doing really well. So we are very happy about that. Just a few conclusions to finalize the case. Remember, for synchronous coronary and cardiac and carotid disease, if we have a symptomatic stenosis, and a stage or synchronous intervention should be considered. Endarterectomy is the first option according to the guidelines. Timing is still controversial, so it's up to you and your team when and how is the best way to treat this patient. But remember, it's better to have as many tools in your armamentarium as possible, because these kind of patients are quite challenging, and CEA is great, but it's not for everybody. So thank you for joining me in this case discussion. Thank you for sharing your feedback, and I hope we'll meet soon in the future. Bye.